I'm Jonas and I work for the Athens Institute for Education and Research, which is a world association for academics and researchers. I'd like to welcome you to Atmer's interview series, where we interview the participants that attend our conference in Athens. Today I'm going to be interviewing Dr. Jonas Stephen, who is an emeritus...
Stephen Jonas, actually.
Sorry. Dr. Stephen Jonas, who is an emeritus professor at the Stony Brook University in the USA. Hello, welcome to Athens.
Good morning, thank you very much.
So, can you give me a brief academic introduction of yourself?
Sure, I was a professor of preventive medicine for 43 years at the medical school at Stony Brook University, which we now call Stony Brook Medicine. And I'm from New York City. Although I've traveled widely, this is my first time ever in Athens, and just certainly enjoying this beautiful city. And I think the very, very interesting conference, going very well, and obviously people from all over the world. Very interesting for me to meet so many people and hear many different perspectives about different kinds of research that people are doing.
So what is your major area of study?
Well, I've had several over my lengthy career. I started working in what we call healthcare delivery systems analysis. I spent a lot of time studying the U.S. healthcare delivery system, and I created the first textbook ever on the U.S. healthcare system, first published in 1977. It's currently in its 11th edition. I have not been active on it since the 7th edition, but very happily my name is on it forever. It's called Jonas Kovner's Healthcare Delivery in the United States. I have also done some research and work in the area of medical education reform. I published a book on that 4 years ago on what was then called problem-based learning, which is now, not because of my book did not attract too much attention, but it was nice to get there first because it's now widely used in medical schools, at least in the United States. I also have done a fair amount of work in exercise and health, both on the health provider side, and also I happen to be a triathlete starting my 35th season this year, and I wrote the first book for beginners in the sport of triathlon, published in 1986, called Triathlon for Intermediates. Leading to what I spoke about at this conference yesterday, which is drug policy reform. I started working in that area about 25 years ago. Actually about 30 years ago. I was, I think, the first developer of what I call the public health approach to drug policy, which actually is based on a very successful program in the United States and many other countries on smoking cessation. In the United States, the National Smoking Cessation Program, which has been underway since the publication of the first Surgeon General's report in 1964, has reduced adult cigarette smoking from 45% to 18%, and we did not lock up one cigarette smoker to do that. In my view, all of the potentially addictive drugs should be grouped together. The distinction between licit and illicit is an entirely artificial political distinction, and this is the subject of my most recent book, which is called Ending the Drug War, Solving the Drug Problem, the Public Health Approach. And that was the subject of my presentation yesterday.
So how do you believe that we can end, like drugs can end? Or do you think it's more of an addiction problem more than just as an individual substance? Or
well,
because you said to take them all together.
I think, first of all, I think that the drugs that affect mood, affect the brain, affect thought processes should all be grouped together. And I call them the recreational mood-altering drugs. And it happens that the most common recreational mood-altering drug used around the world is none other than caffeine, which of course is in coffee and tea. And caffeine is a mild mood-altering drug for most of us, including myself. It wakes us up somewhat.
Yeah.
We know, for example, that ethyl alcohol, which is the active product in alcoholic beverages, has been used in human culture, at least since biblical times, and since it appears in the Bible. It was probably used a long time before that. It's very common. Currently, alcoholic beverages are totally legal. But alcohol consumption can be very damaging. In the United States, there are 85,000 deaths a year related to alcohol. There are still 488,000 deaths a year related to cigarette smoking. And of those, about 49,000 are in people who never smoked, but who were poisoned by secondhand smoke in various places. One of the major accomplishments of the smoking cessation program in my country and in many other countries has been, for example, to limit where smokers can smoke. So in my country, they no longer smoke in restaurants and bars. Most office buildings ban smoking. Certainly health sciences facilities do, and some of that stuff. This has been very effective in terms of smoking. And the smoking-related deaths are going to go down over time, but we still have a very large number of them. And then I would approach the currently illicit drugs by grouping them together and grouping them together with the licit, so-called licit drugs, and adopting the same kind of program that has been so successful for smoking consumption to all of the drugs.
So how does this program work that you're...
How would it work?
Yes.
Well, certain of the current illicits would be legalized. Marijuana, for example, is being legalized in an increasing number of states in the United States. Heroin can be very dangerous if the person taking it doesn't know what's in the dosage they're taking. The majority of heroin overdose deaths occur in people who accidentally overdose on heroin because they don't know how much heroin they're injecting into their veins at a particular time. So for example, I would sell heroin in what in the United States were called package stores. That is literally the states owned stores for selling that substance. After the end of Prohibition in the United States in 1933, most states, alcohol at first was sold only in package stores. Now, of course, it's sold widely, it's advertised widely. The beer industry spends $2 billion a year advertising their product. And as far as the argument that, well, if you put the drugs out there, people will use them, is concerned, if that were true, why does the alcohol industry spend so much money advertising their product? If you just put it out there and people were to use it, they wouldn't have to spend all that money. The fact is that after the end of Prohibition, it took the beer industry, beer virtually disappeared from the market during Prohibition in the United States, because beer is big, or was big. The breweries took up lots of space. You have to drink a lot of beer in order to get drunk. It's foul-tasting stuff. I don't drink beer, but it took the beer industry 30 years of advertising after the end of Prohibition to get the consumption of beer back to the level that it had been before Prohibition. So there are a lot of myths out there which are promoted by the drug war people. Cocaine, I also would sell in package stores. Most people who use cocaine are not habituated. They're called chippers. They use the stuff on weekends. Cocaine addicts only about 20% of people who try it, whereas nicotine in cigarettes addicts about 95%. Nicotine is the most highly addictive recreational mood-altering drug we have. As for other substances like the methamphetamines, that would have to be given careful thought about how exactly that would be distributed. But we know the negative effects of the drug war. The imprisonment of vast numbers of non-violent so-called drug offenders, most of whom are African American or Latino. 75% of the users of the illicit substances are white. 75% of people who are in prison for various drug-related, so-called drug-related offenses are not white. So we have, of course, the United States has the highest incarceration rate of any country in the world. The United States has a very profitable private prison industry, which doesn't exist anywhere else. So I think that a program, I think it would not be too difficult to develop a program because we have the model. And the model is a very successful smoking cessation program, which the components are advertising. They are limits on availability that, I mean, anybody can buy a pack of cigarettes, but their stores are no longer allowed to put them out front. They have to be on a counter, on a rack behind the counter. Messaging on packages is very, very important. The limitation of where you can smoke. And of course, price. There have been a number of studies that show that cigarette smoking consumption is definitely related to price. As addictive as nicotine is, the higher the price, the less cigarette sales there are. So these are all components of a successful program that we could use for any of the addictive drugs.
So, how were you introduced to the Athens Institute for Education and Research, and what made you attend the conference?
Okay. Dr. Papanikos found my email address somewhere. I think he probably found it because about a year ago I published a paper that summarizes my book on the subject, which I've just summarized for you, in an online open source journal. And I think I have to ask Dr. Papanikos, I think he found my name there. And so I received an email from him. I was interested, first of all, I'm attempting to publicize and promote the book. I went, last month I was at an international conference at the International Society for the Study of Drug Policy in Denmark. And talked to people about the book there. I did some presentation on it. So there was certainly an opportunity to do that here. Second of all, or maybe it was first of all, I am very widely traveled, but I have never been to Athens.
Okay.
So I said, what an opportunity. And I think that I also, so I was attracted, first of all, the chance to do a presentation. Second of all, the opportunity to come to Athens. Third of all, the construct of the conference where Dr. Papanikos combines presentations with the opportunity for tourism. And I thought, this is a charming idea. The American Public Health Association doesn't do that. The Association of American Medical Colleges, these are meetings I used to go to, they don't do that. But you get a proposal and you say, okay, there's 2 days of conference, and then if you want to, on the third day, you can take a tour to Delphi, which is what I'm doing tomorrow. On the fourth day, you can go for a boat ride on the Aegean, which is what I'm going to do on Thursday. So what a great combination. So that's what attracted me.
Very nice.
Yeah.
Well, we hope we have you again. Thank you very much.
Okay, thank you very much for the